What I'll do is pick up almost exactly where Rasu left off and to share maybe more from a policy perspective where, as a nation, we're grappling with the healthcare crisis. While we are looking to open up, I wanted to point out a very critical failure in the system today, and that is the lack of the underlying information necessary for public health investigations. When the first round of COVID positive patients were reported, the CDC published in March a report on, I think, sort of 4,000 plus patients. And I wanted to point out a headline in the article that was a bit shocking to me, having spent a decade in the public and private sectors to modernize the system. Quote, "No data on serious underlying health conditions were available. Data are preliminary and missing, whether or not the patient was hospitalized, whether they were admitted to the ICU, whether the patient died, and even, unbelievable to me, what the age of the patient was that was COVID positive." So it is a bit of an abysmal circumstance whereby the healthcare delivery system has invested $35+ billion over the last decade, and yet most reported cases to public health were coming in through phone and fax. We are now entering this next phase where we need access to information in order to make granular decisions about whether we're going to open up elective surgeries or not, we're going to open up the economies or not, and community organizations like COVID Act Now and others are springing up to try to fill in the gaps with as much information as can be made available, both for policymakers and, frankly, the public. I won't spend too much time on COVID because I think Rasu did a nice job describing the provider perspective about the nature of the challenge. I'm going to lift up more broadly about where we were going in to COVID. And that is a crossroads on the healthcare delivery system. As I think many of you know, both political parties want to constrain healthcare inflation to something equivalent to GDP plus zero. That's a bipartisan commitment. And having served as chief technology officer, part of the argument is that we need to reinvest the savings that would come from a slowing growth rate in healthcare into American competitiveness. So if you were to look at the industries of the future, many of which are technology driven or data driven, you'll learn that our competitors globally are out investing the United States, and that is causing great concern in Washington. Now, having said that, there is this small coalition of the willing. We'll see how big it is. Maybe some of you on the webinar tonight are in this camp, but the argument is that we need to find a way to open up our, more importantly, find a way to deliver higher value care at lower cost. For those of you who have been following the value-based care movement, there's the perception that, this is achievable, that, whether it be Don Berwick's study about waste at 30% or it be any other reports that have been out there, there is this sense that we can have our cake and eat it too. We can improve quality and lower the rate of inflation. On the methods, if you will, it's pretty straightforward. We're going to open up as much information as we can about the delivery system. We're going to tweak the financial incentives so we can reward better outcomes. And we're going to empower consumers and the organizations with whom they trust to better navigate the delivery system. And the goal is, if we do this at scale, we're going to have lots of experiments, rapid prototyping, rapid validation, and then hopeful scale of what works. We are aware, I'm in this movement, by the way, so you can imagine I'm a card-carrying member of this, maybe it's a religious faith, I don't know what it is. There is a dose of reality that we have to acknowledge. That is some of the shining lights examples on how to do this. The Camden Coalition, the MacArthur Genius fellow that was at the heart of the movement, published results late last year, where a proper randomized control trial was run. And unfortunately, despite all the wishful thinking that the models about going after the very sickest of the sick, tackling their social needs and a variety of other factors, the hope that was going to be enough ultimately we suffered from the traditional economic problem, reversion to the mean. When asked about this, the CEO of Geisinger, Jaewon Ryu, an organization I'm very proud to work with, was asked by the podcast hosts, we've been betting pretty heavily on value-based care. What happens if this move to value doesn't work? What if there's sort of a mass exodus and physicians just say, you know what, I'm done with this? The answer is exactly where, those of us in the movement are at. And that is, I really hope we don't get there. If we don't, the alternative is draconian land, as Dr. Ryu said. And draconian land basically means healthcare on a budget. We're going to capitate. That could mean Medicare for all on the left, and it could mean Medicaid block grants on the right. And it'll be more about cutting the rates without any real underlying change to the delivery model. So we've got to avoid this. So what I'd like to do is spend the next, maybe 5-10 minutes walking through the argument about how we're going to get there if you wish to be a part of this movement. Number one, open data must be enabling infrastructure. Now, I don't know how many of you liked this, but back in the Obama administration, we changed a policy which meant that any person in the country can look up any of you and to find out exactly how much money Medicare paid you. So this is the Wall Street Journal's website. I searched the highest paid doctor, and that was, I blanked the name, but it's actually it's an Arizona-based doctor. And what we, the nature of the opportunity is you could sort of see the reality. This doctor was paid $11.1 million from Medicare. It wasn't in the traditional visits. It was about $8.8 million because this particular doctor injects essentially Eylea or Lucentis at about $2,500 an injection, when the $50 compounded version of Avastin was deemed by the National Institutes of Health as clinically equivalent. So shining light on performance will start to help people. Imagine you're a senior. You don't have a Medicare supplemental plan. You have to pay 20% of the coinsurance. Your doctor tells you that you're going to lose your eyesight and that there is a way to solve this. We'll inject your eye, and God bless America. That's really, really important. But may not explain all the options, and that you could have had a 20% copay on a $50 injection versus what is today a multi-billion-dollar market. In fact, I wrote a white paper for any primary care doctors on the Zoom tonight. 25% of Medicare ACOs that failed to earn a shared savings check but made Medicare some money would have gotten a check if only 15% of the patients that needed the injections got Avastin instead of Eylea or Lucentis. Imagine the millions of dollars of bonuses that would have gone to primary care doctors if only a fraction of the patients under their responsibility were navigated to a lower cost option. Similarly, Medicare is opening up data. There's a 4-to-1 return on investment if you take a pre-diabetic patient and you enroll them in the YMCA Diabetes Prevention Program. Rasu mentioned his work with the YMCA. The results were so overwhelming. I put out this $1 billion innovation challenge before I left the White House, and this was one of the winners of that grant project. The results were so incredible. In 2018, every doctor in America could prescribe a free voucher to get the YMCA's Diabetes Prevention Program. Hundreds of thousands of patients would be eligible, 4-to-1 return on investment, an absolute no-brainer. And guess what? Despite the results, instead of hundreds of thousands of patients getting the benefits, only 200 plus patients nationwide were enrolled in the program by the end of 2018. That number's gone up. We're now probably closer to like 800, but not 800,000, 800. Lastly, shining light on the system is helping us understand some of the bizarre documentation and billing gaps. When you switch from Medicare fee-for-service to Medicare Advantage, the financial incentives change a little bit in that there's more value inaccurately recording the severity of illness on the patient who's now moving into a Medicare Advantage program from fee-for-service. That arbitrage has been a huge source of debate. That is to say, the patient's just as sick as they were last year as they are now, but because we never documented it in the traditional fee-for-service setting, no incentive to document it, we created a financial windfall for the Medicare Advantage plans who simply had the benefit of rewarding accurate documentation. Last year, Medicare Advantage data was publicly available for the first time. Care Journey, the company I run, we have a license to all of this underlying data. So we asked the question, who were the patients that flipped from fee-for-service to Medicare Advantage? And just what did we learn? We found a cohort of 600,000 people who flipped, and the prevalence rate of those who flipped, the rate of morbid obesity in that population doubled in 1 year. Now, I don't believe they were, going to In-N-Out burgers or whatever you all eat out on the West Coast, but clearly the documentation gap, that translates into thousands of dollars of revenue to the Medicare Advantage plan per patient that gets this sort of upgraded diagnosis. So this is where we are on the open data movement. And if you could throw tomatoes at me through the video, I'm sure many of you might. We are entering the era in the Affordable Care Act that called out that the reason Medicare would release this information is to encourage the development of rating systems so consumers can better navigate the delivery system to doctors that deliver high-value care. We are very early in the ability to use this data in this way, but we, Care Journey, are committed to doing so in as open and transparent a method as possible. I blanked the name of this orthopedic surgeon, put my name in there. This is an actual physician. This represents how well that physician performs on certain cost and quality measures as benchmarked against their peers in the geographic region in which they practice. This particular physician is reasonably effective when it comes to joint hip and knee replacement surgeries. But when it comes to the hip and knee replacement surgeries, except the joint, much fewer procedures done by this surgeon, much higher costs on a Medicare population relative to what his peers were looking like in the same geographic market. Now, all the research questions that are out there, what is the appropriate risk adjustment, and how do you factor in social demographic factors? All of those questions are appropriate, and we're entering the era where that debate will happen. The public will have access to this information somehow or another, which leads me to the main event. Those of us in the delivery reform world, we've tinkered around with managed care, HMO or not. We've tinkered around with ACO models and incentivizing physicians. There's really, a few options on the menu left that we haven't fully explored as a country. And one of them is to equip consumers using the smartphones that they now have in their pockets with the kind of supercomputing navigation decision support so that they can make smarter decisions along the way. If my family members qualified for the YMCA diabetes program, I would like for them to ask for the voucher and get the service and hopefully stay healthier without having to go full board diabetes and need all the intervention. That's why the government, ONC and CMS, have regulated that all of these systems have to be made open to the individual patients. So you could see the rise of Apple Health, the requirement that all health plans, government-sponsored, and all doctors and hospitals have to connect if a consumer wants it. And you can ask the question, is this going to cost me an arm and a leg? This has got to be really difficult. Apple keeps a list of every doctor who's live on their system. And the very first doctor listed is Richard M. Adams of Family Foot Care of Texas. Now, Rasu, he's not a billion-dollar health system like Atrium, and yet he found a way to make it happen. I don't believe this is going to be very expensive. The headline here is that over the next 12 to 24 months, these new rules that the government has imposed will mean health plans have to push out information to consumer apps. Physicians are going to have to make available the information to consumer apps, and the infrastructure that would facilitate the consumer data sharing can be and will be repurposed to strengthen the payer-provider data sharing, which has been such a hassle so far. Now, in California, every primary care doctor today can apply to go basically full bore capitation for Medicare fee-for-service. It's a program called Primary Care First. It goes live next year. Applications were due. I think they're coming up now. And you can see that CMS is going to move away from the traditional, fee-for-service medicine and really create more of a budget and a per kind of a monthly fee, a stipend, and to help get organizations driving. This program invites private health plans to join Medicare. And I don't know if any of you have applied for this service, but I'm excited to see what you may do. From my vantage point, it's about hug a doctor that's taken on capitated risk. In California, that's been long-standing truth. We've got to understand what it is that we can do to practice medicine in this new way and scale it as rapidly as possible across the country. Last couple of points. One, nothing in this next chapter of healthcare will work unless we earn trust. Consumers have been asked, who are you willing to trust with that information? Is it going to be Apple and Google? Look at them at the very bottom, tech companies, 11%. I don't think so. I think the applications they'll trust are going to be the applications that are given to them by their physicians. Overwhelmingly, 72% trust for physician data sharing. In my view, this new era of consumer-centered delivery will be anchored by a trusted application that operates sort of like a health information fiduciary, an organization that is critical to assembling all your medical records, working with your physicians, and providing for you the kind of decision support that's needed to make a difference. I'll end with this. You may hate your EHRs, and I'm guessing for many of you, that is like a four-letter word. We are entering an era beyond the EHR. We are going to now see the development of apps, just like we can download apps on our phones to delight our family members for photos and videos and movies. We too will see an era where doctors can download apps that help them solve their immediate needs, and they don't have to make a gajillion-dollar investment in this crappy EHR system that's been regulated for the last decade. This is an area where you'll see a great deal of innovation. The American College of Cardiology has open sourced the Million Hearts calculator. I worked with a team at MedStar to build a free calculator that doctors can use. Over 1,000 physicians in Maryland are now automatically computing the 10-year risk of a heart attack and enrolling patients in delivery models as a result. CMS has allowed every doctor to download all of their claims history for every Medicare fee-for-service patient they treat. And in Rasu's backyard in North Carolina, the governor has put in a new Medicaid program anchored around improving social determinants of health. And we've open sourced an app that would allow for physicians to screen patients and to make that screening information interoperable. So I went long, apologies for that. But Archana, I'm excited to engage in a bit of a dialogue if that was helpful information. And as long as I didn't scare anybody, I'm keen to be helpful. I see some of these typed in here on the start, but I'll defer. Rasu, you and I can go back and forth, whatever we make sense.